that they have not gotten their share of Medicare reimbursement dollars. Now let me give you a couple of examples. The Cleveland Clinic, the Mayo Clinic. They want that hospital issue revisited. And they want, please, they want that reimbursement formula altered. Hence, we decided that we would allow, as I indicated a moment ago, the Institute of Medicine, which tends to be made up of professionals rather than just bean counters, so that they might make what we would consider to be a judicious analysis of that formula. That's one of the things that I'm very concerned about in this plan. And that is that there are other parts of the country, including the Pacific Northwest. And recall that the teaching hospital at the University of Washington at Seattle is rated one of the 5th best. We've got 2 in the top 10 in U.S. News and World Report. They've got 1, and they are come to believe that they should be getting more. Now, if you're not going to grow the pie, which generally has been agreed to, that means that the slice that they're looking for has to be bigger from within that pie that I just described.
And that's a concern that I have and the entire delegation has. The fact of the matter is that the cost of living here is more expensive than it is in Yankton, South Dakota. And so if Yankton, South Dakota, wants more, but they are not willing to talk about expanding the pie, then you're robbing Peter to pay Paul. The fact is, well, look, the question was, what are our concerns about the current bill that's working its way through Congress? We are trying to fight to make sure that it is acknowledged and recognized that the cost of living here is higher than in other parts of the country. That the cost of medical care, in turn, may be higher. That we have teaching hospitals here, and we have some of the best hospitals in the world. When people get sick in other parts of the country and around the world, they come to Massachusetts for their care. So, that's kind of one of the issues that we are flagging, and we are working with the Speaker and working with others to try to make sure that that is recognized in any final bill.
They come here from Canada, too.
Yeah, they come here from all over the world.
So there are several questions that use the term rationing, healthcare rationing. Is there anything in the bill which would allow doctors to deny any particular healthcare, and if so, on what basis? Others talk about rationing of MRI.
There is no rationing in this proposal.
And let me just also kind of state kind of a fact. And I think this is the same for Congressman Neal as it is for me. The casework that we get with regard to medical issues, the vast majority of it is with people who have insurance, who get sick or have a loved one who gets sick and all of a sudden find that they're not getting covered. So if you want to talk about rationing and you want to talk about denying people care, there are flaws in some plans right now, in some systems, that deny people care when they should get care. Where they call us to get on the phone with the insurance company and try to make sure they cover something. What we want to do is move away from that. What we want to do is essentially, guarantee people the peace of mind that if you are in an insurance plan, that basically you will be covered. And you don't have to worry about, well, if I have this illness or that illness, will I get covered? We have seen people go bankrupt over medical costs. And it is unacceptable, and we're the richest, most powerful country in the world, and that shouldn't be the case in this country.
Obviously, people. Obviously, there's a lot. There are many fears, and certainly stirring up fear is an effective mechanism sometimes used. But one of the fears expressed on one of these cards is the fact that to establish reimbursement rules, Washington will require our health care records on their computers. So there's a concern of an increased risk for invasion of privacy under a plan in which there is a guarantee of access to coverage. Does either one of you want to address that?
Look, I'm one of those folks. I think that in a free society, that privacy is next to liberty. And, well, no, that's not a good example. In this instance here, there is probably always going to be a danger that the wrong button on the computer is hit. Those things could happen, but I think that, by and large, the idea of using technology, which everybody in this room who's under 30 can utilize without any problem whatsoever, that you understand that's the conversation of the future. And I volunteer to have my records put someplace where that a doctor can access them in an emergency. I think that's a desirable goal.
The other thing is we're trying to cut down on medical errors. Now, I don't know if you've ever seen a doctor's handwriting, but you know the reality is that the old way of doing things is not necessarily the best way of doing things. And the fact of the matter is, if you're like, you know, my parents, you know, they're here all, you know, during the calm months, and they like to go to Florida during the winter months. If my father, who has a very complicated health history, gets sick in Florida, I don't want them repeating the same test that they did in Massachusetts. And so what we want to do, with respect to privacy, I mean, absolutely, and that has to be tantamount. But you have to concede that we can do this a little bit better, and technology can play a positive role in helping reduce medical errors and reducing costs, because we're trying to save costs.
What are you saying? The government is going to take care of that, you're saying.
So there's,
The government's going to take care of it.
we have,
No, we're not saying that.
we have one more, time only for one more question, and then we have to ask Dr. Ettinger, President of the Medical Center, to sum up for us. But the one comment, I'll read one which is a comment, and then the other is, I think, a very pertinent question for us on this campus. So the first comment is, I want you to know that there are many among the physician community who support healthcare reform and the public payer option. And the second, that was a comment, but another related question, particular to physicians, is how are we going to provide this care without training more physicians, or I think conversely, how are we going to provide this care by providing training more physicians?
Can we just have one more question? The lady in green? Yes. Okay, go ahead.
I just have one question that's been avoided in the interest of total candor. We're talking about cost savings and so forth. Page 425 of the bill alludes to this, and it's talk on the radio all the time, is comparative effective research, which is basically a code you all are using to decide at what point in time people will in fact be denied protection.
I don't think that that's the case, and I'm going to tell you why. What you're trying to do with that is what any business person does in an attempt to figure out what works best.
Have you read it?
I have read it. Yes, I have.
That's exactly
I have. And I'm responding based upon the question that the lady has raised with me. And most businesses would say, what can we improve based upon what we're doing, based upon the empirical data that's in front of us? Now, I'd like Sibel to maybe take a crack at that as well. Sibel, would you take a shot at that?
It's denying the elderly.
Sure. Actually, on pages 425 is back on sort of the counseling, the voluntary counseling session on end of life. There's another section of the bill, however, that deals with comparative effectiveness research, and that is really research that's funded and geared toward producing independent and unbiased research so that patients and their doctors and nurses can have the best knowledge about treatment decisions, and those decisions are not affected, and the research is not affected or influenced from the pharmaceutical or device industries who may have a stake in the outcomes, so that people can really determine, that the doctors can determine in consultation with the patients what's going to work best for them. And that's really what CER is, sort of pure and simple.
So, just a slight follow-up for clarification, so nobody's getting a misinterpretation. Let's call a spade a spade. Will there be a point in time when a poor old soul, the plug is pulled, and you're told, no, you cannot have a bypass because the cost-benefit ratio is such that the actuarial table said you should only live about 2 more years, so you can't have it. Is there anything about this bill?
That's what it's all about.
That's what it's all
No,
about.
there's not. And there's nothing in the CER section. The CER section is focused exclusively on sort of the effectiveness of treatments. There is nothing in there taking cost into consideration. It is
Maybe let's address this from the academic point of view. There's actually an inverse correlation between the amount of money that a state spends on healthcare and the actual quality outcomes in most cases. And so much of that is because in the absence of evidence-based medicine, physicians are influenced by a variety of things, including fear of litigation, including influence of pharmaceutical and device manufacturers. And there's quite a bit of scholarly research ongoing on this prior to having anything to do with this proposed healthcare reform. But I'll let the Congressman have the last word before Dr. Ettinger closes.
Yeah. That's unfortunate. Look, in answer to your question, no. And we would not support a bill that would do that. And we could argue about the semantics, but that is not what the intention of that provision is. And what we're trying to do is figure out what are the best practices. I mean, how do you know? In some areas, in some areas, we're keeping people healthier. In other areas, we're not. What's working here that's not working there? What are the practices that are working here that can be replicated, you know, in other parts of the country? What are the best practices? Not to try to save costs. Although I will tell you that if you do best practices, if we emphasize prevention, you will save costs. This is not in any way about saying that you can't have a bypass surgery when you're 99. There's nothing to do with that. That's not what this is about. And it is just, it's wrong. Quite frankly, it is wrong to try to turn that provision into that. I'm telling you right now that that is not the case. We would not support it. And we do strongly support medical education. Because, quite frankly, we need more primary care physicians, we need more doctors, we need more nurses, we need more medical research to find cures to diseases. So that's a way to save money too. You find a cure to Alzheimer's disease, you'll have no problem balancing the budget with regard to Medicaid. So we need to invest in medical research as well.
Is it not true that insurance companies today do pull
Insurance
the plug?
companies today do make choices for you.
That's right. No, they pull the plug to save the money. Exactly what they're trying to say is in your bill. Insurance
Thank you very much
companies do it all the time.
for this very spirited debate. If you have other questions, you can submit them to your websites. Is that correct?
Yeah. The gentleman up there who had the business, make sure you get us the question, the information.
Yes. So we're going to adjourn now because the congressmen have other appointments. Thank you very much, ladies and gentlemen.